Well, let me very quickly start by saying that it is indeed for me a pleasure to be here and to be talking to all of you. And I'm really impressed with the fact that there's a country which has over 400 health economists. I don't know of many, certainly not in my part of the world where I work. So that's a very good start. Having said that, of course, you also have a huge challenge in this country and in the region. So what I'm going to talk to you about is the challenge that we have in moving towards universal health coverage. And you have heard about universal health coverage, and I'm sure you are working in this area as well. So let me throw before you some of the challenges that are faced by low and middle income countries, but also touch on some global challenges that we have in the area of universal health coverage. So if we look at some of these numbers across the last, or across 10 years between the year 2000 and 2009, and I'll focus on the low and middle income countries, you can see that the total health expenditure per capita was around $14, which has now gone to around $30. And these are unweighted averages in low income countries. And of course, I have to say Bangladesh falls in that category. But if you look at other countries as well, the message here is that the total expenditure in health has gone up. And if you look at the global expenditure and the global estimates, then currently it's somewhere in the region of $6.5 trillion. So that's a huge number that we are talking about. For Bangladesh, of course, the numbers are much smaller. So if I turn to the region where you work, of course, WHO, where I work, is divided into 6 regions. And the region that we're talking about here is the Southeast Asian region. The estimated per capita expenditure, total expenditure, is around $58, and the government's expenditure is $23. Now compare this to Bangladesh, the numbers are lower. So Bangladesh, I think the numbers are somewhere around $21 or $22 for total expenditure, and for the government expenditure, I believe $7 or $8. So there is a big challenge that you have to tackle and look into, how we could have more funds for the health sector if we have to move towards universal coverage. Now this, I think, is an important slide and worth spending half a minute at least. If you look at this at the bottom and the x-axis, what you see is the share of out-of-pocket spending as a percentage of total health expenditure. And what on the right you see the percent of households. The message of this slide is that when household expenditures go around 30% or higher, then the risk of financial catastrophe and the risk of impoverishment becomes that much higher. And so if you look at the category where I believe Bangladesh falls, somewhere that's between 60 to 70% of their share of out-of-pocket spending, then there is a risk that almost 3 to 4% of the households at least incur catastrophic expenditure, and about 2% actually get poor. Now the message clearly is any health system that instead of protecting pushes its households into poverty cannot be called a fair health system. And that's why we are all hoping that we will be moving towards universal coverage in order to be able to protect the poor. I'll skip this slide, but what quickly shows is that the share of out-of-pocket spending in the lower income countries is high. And again, I've talked about this, so I'll move to the next one. So of the 36 countries across the globe where the share of out-of-pocket spending is more than 50%, many are in this part of the world. India is, Pakistan is, Bangladesh is, and so there is a huge challenge for the countries of South Asia to be able to move on from here and really try and tackle up front the big challenge of high share of out-of-pocket spending. Now, one trend which is perhaps not that encouraging in Southeast Asian region is that the trends in the government's health expenditure as a percent of total government expenditure is not that encouraging. And perhaps over the years that I can see from our data in WHO, it has actually gone down from around 10 or 11% to around 7%. And that means that there is need for more allocation to health, and we will talk about that, how those could be addressed. Now, before I finish on the challenges, I think this is worth a slide which has 4 parts. Don't go into the details, don't worry, it's too detailed. The red colors reflect expenditure on education. The blue boxes or blue box plots reflect expenditure on health. And it's a comparison of low income, low middle income, higher middle income, and high income countries. What it is showing is that in low income countries, more is spent on education than on health. But as populations age, as countries develop, then the expenditure on health goes up as compared to education. Clearly, Bangladesh falls in the first low-income category right now. So to summarize, what are the challenges facing health financing reform in low and middle income countries? I'm very pleased to see that there is a health financing strategy, because most countries need that. And I think I must compliment your country for taking a step forward. And that's why you need a clear vision. It's not just about reaching, but to have a vision is so important. And I think you are making good progress in this area. But the other challenges, of course, are insufficient and unsustainable funds, fragmentation of health systems, the large informal sector that we talked about earlier, and the part of the world that I work, there are countries with huge complex emergencies, so Iraq and Afghanistan and Palestine and Sudan and Libya, and so there are plenty of countries where we have an additional challenge of chronic emergencies and conflicts, and of course inefficiencies in the use of resources. So what is the opportunity then? The opportunity is, and coming from WHO, don't be surprised, I will say, and I will quote, of course, my Director General, that universal health coverage is the single most powerful concept that public health has to offer. And it's not just WHO, but even in the last UN Assembly, this notion of universal health coverage has been fully endorsed, of course, as a means to achieving MDGs. This very much is in line with the WHO, or the Primary Healthcare Alma-Ata Declaration of 1978, and which the main aim was health for all, although they're not the same, but they're closely related. So what is universal health coverage? I will just suffice by saying 2 points. First, people should have access to preventive, promotive, curative, all sorts of services, but they should have access to services without any risk of financial ruin or financial hardship. And if that can happen, and I think here, I would say your country has made progress from a programmatic perspective. So your family planning programs and MCH programs are doing really well. What you need to do is to see how it could be done by giving financial protection to the population, which I think still remains a challenge. So what I'm going to present to you is what we now call the famous cube, which has 3 dimensions. And any work on universal health coverage has to look at these 3 dimensions. I'm afraid that is quite important. One is covering the population and widening your coverage from whatever that group, formal sector, informal sector, the poor, the vulnerable, and so on and so forth. The second is covering the costs. So who is covered, who is not covered. The second is, okay, covering the services. And so I think it's an important decision early that needs to be made, what kinds of services need to be covered. Rest assured, there is no country in the world that can cover all services. And based on your national burden of disease, you will need to make a quick decision. What are those services that need to be part of the essential package of services that falls under the ambit of universal health coverage? And of course then is, how will those costs be covered? So a financing strategy anywhere, I believe, should look at who is covered and how progressively the population groups will be covered, what services are covered, and what is that essential core package that needs to be covered, covering everybody, and then how those costs are covered by moving from direct out-of-pocket payment at the point of service delivery to prepayment. Now here I do want to emphasize that as WHO, we are not proponents of social insurance or tax-based financing. What we are emphasizing is prepayment, whereby we promote risk pooling, and countries then can have a choice or a mixed system based on the pros and cons of what their systems are like. So the key word again here is on emphasis is on prepayment. Now I will skip a few of these slides because I think I need to go on to a few more. In terms of the challenges, so what are the 3 big areas, if I could say that, given my policy perspective? Of course, we have to look at this. Let's not forget about the social determinants of health, which means education, employment, social exclusion, and all those things need to be factored in. And I think they do have a role. Then we need to look at health system challenges other than financing. And I think it was alluded to by Dr. Ashad or Mr. Ashad earlier on about information systems, service delivery, human resources, technologies, medicines, and of course is the challenge around having a well-functioning financing. So those 3-pronged approach will be quite useful when you are looking at an overall strategy for health reform. Now, what are we purporting, and I don't know whether you're aware of, but in 2010 we had a World Health Report on universal coverage, which I think has been well received by our member states. It is giving three big messages. How do we address the problem? First, we need to have more funds, and I think there's no question, and we have to find innovative ways of mobilizing more funds. Second, we need to have more funds in pooled manner and move away from direct payments into and reduce out-of-pocket payments. And last, we need to be more efficient and more equitable, and there are huge rooms for efficiency gains with the resources that we already have. So more funds, more pooling, and more efficiency. In terms of insufficient funds, clearly the challenge is to have more funds, and the figure that we are saying that by 2015 we're talking of around $60 that should be there per capita for having a reasonable package of services. I will not have the time to go into the details, but we need to have more funds and more predictable funds. I will skip the slide because this relates perhaps to high-income countries. What are the options? Health has to be high on government's political agenda. Without that, it's very difficult to get more funds. And so, as public health professionals, as health economists, you will have to promote that. And it's not just about technical work, it's also about communicating this in a manner that policymakers understand. Also raise revenues more efficiently, and I think we need to hear from our minister from Indonesia, their experience of how they have been able to almost triple funds in the health sector, especially the public sector, to be able to provide more protection. But there is also an opportunity of more taxes, whether you do some indirect taxes. There are what are called sin taxes because of tobacco. I don't think alcohol is that important in this country. Levies, and I think what was discussed last night is the option of looking at how we could get some for health through foreign remittances. That is an important source of revenue in Bangladesh. Then the second one, and I'm really running through because I need to finish in time, and I can see Paul says 2 minutes, but I'll try and finish in less than 2 hopefully. Direct payment is important, and I think 33 countries in the world are there that have spent more than 50% of their total health expenditure through direct. And so how do we reduce that? Think of reducing or eliminating charges from government health facilities, especially for certain target groups, mothers, children, patients who have TB or HIV or what have you. Looking at prepayment schemes that we have talked about, introducing voucher schemes, micro-insurance schemes, which of course need to be then merged because we can't have too many, and of course making contributions compulsory from taxes and insurance. Coming quickly to the third and the last part is inefficiencies, and the report again talks about 10 major areas of efficiencies. They relate to medicines, they relate to the delivery of services, they relate to health workforce. It means inappropriate positioning and placement of workforce, and of course it relates also to wastage, corruption and fraud. And what I can tell you from the work of WHO that almost 20 to 40% of healthcare expenditures actually are wasted, and there are huge opportunities for efficiency gain with better governance, better transparency and better accountability. Finally, how to protect the poor and the vulnerable, and I think that is something which has to go we can't wait for this. This has to be done upfront and as a priority. And so there are options of seeing how they could be done through a free or subsidized service, through free insurance contributions, and sometimes through cash payments for their transport costs and so on and so forth. And this, of course, has to come from the public sector. It's very, very difficult for poor to be paying for their own health care. And that's why it's a big challenge for any government to do so. So to come to the last slide, UHC achievement is a journey, not a destination. It will not happen overnight. The countries that have done it are less than 10 years, like Taiwan or South Korea have done 10, 15 years. And I could see that you have a realistic 20-year period, which I think is a pretty good one to think about, But you are right now where you have limited government-funded programs, and there is a high proportion of out-of-pocket payment at the point of services. Progressively, you need to have more prepayment schemes, and progressively you need to reduce your direct payments, but perhaps some limited private insurance, and hopefully in the 2 decades or within 2 decades, you should have the majority of population covered through government revenues, through social insurance, through prepayment schemes, perhaps more private insurance, and perhaps there should be some supplementary coverage. And I think that is that progression that you need, that over the next 15 to 20 years, you should make serious advances in moving towards universal coverage. I'll stop here. Thank you very much.